More than half the patients I operate on for lung cancer are non-smokers and often women. And they're often at the prime of their lives. And this is a disease that doesn't discriminate.
Is lung cancer still a death sentence as it was 10 years ago?
No, I don't think it's a death sentence. We are now able to analyze these tumors at a molecular level, but we are able to improve the quality of life.
Professor Dr. Padmanathan Rajadurai is the Senior Consultant Pathologist and Laboratory Director at Subang Jaya Medical Center with extensive expertise in diagnostic and molecular pathology. His work has significantly contributed to the understanding of cancers, particularly through research in tumor biology and molecular diagnostics.
Dr. Anand Sachithanathan is a fully English-trained British board-certified adult cardiothoracic surgeon with specialist registration in the United Kingdom and Malaysia. He is also the founding president of Lung Cancer Network Malaysia, a not-for-profit patient-centric national-level NGO. Under his leadership, LCNM has developed several national firsts for lung cancer in Malaysia, the first patient guide, first clinic counselling tool, and first clinical practice guidelines. Besides that, Dr. Anand also holds 2 professorships at University Malaya and Sunway University. So globally, it's estimated that 2.5 million new lung cancer cases are diagnosed, and it contributes 1.8 million deaths every single year. In Malaysia, we estimate that there's about 5,500 new lung cancer cases every year, and approximately about close to 5,000 deaths as well. And by ranking, lung cancer ranks third by all new cases and first by cancer deaths overall. But the interesting thing is, to both my speakers today, Prof. Fatma, Dr. Anand, lung cancer isn't a new topic. We've heard it over the radio, we've seen it on campaigns. Why are we still talking about lung cancer today, and why is it important?
Well, very much for what you've said, Leonard, right? It is a very, very common cancer. As you have rightly mentioned in that intro, it is still one of the commonest cancers and commonest causes of cancer death globally. And based on our own local Malaysian data, the most contemporary data we have is from 2017 to 2021. And we know that among males, it's the second most common male cancer, only surpassed by colon cancer, but the commonest cause of cancer death in Malaysian men. And in women, it is the third most prevalent cancer after breast cancer and colon cancer, but the second most common cause of cancer death after breast cancer. So, it is a very common cancer and very common cause of cancer death. And I think that's in itself an important reason why we're discussing it today. The disease burden is still very high globally, including here in Malaysia.
Also, we must remember that not only is it a common cancer, it's also one of the leading causes of death. And very importantly, it sort of afflicts persons who are in their most productive stage of their life. And second thing is that there's been a lot of advances, and it's no longer a disease where one makes a microscopic diagnosis and the patients are treated as they were 10 to 20 years ago. So subsequently, there have been tremendous advances. And that's why it's continued to remain and in the focus, patients' focus, public focus, and certainly a very exciting area because changes are developing almost every other day. The way we diagnose the cancer, the way we manage them, because of new information that we are able to extract from a biopsy.
Right. I think certainly, and we had an episode talking about brain tumors, and apparently a lot of brain tumors derive from lung cancers, right? But I do want to zone in specifically to what you mentioned, Prof. Fatma, which is the landscape being different 10 years ago, right? You hinted at a few things, which is the way you diagnose, maybe even treatment, which we can talk about later. But comparing 10 years ago and where we are today, what are some of the most impactful changes that you feel people should know about today about lung cancer?
Yeah, so I think when you look back at the way we used to diagnose lung cancers before, the pathologist would look down a microscope and make a very simple kind of algorithmic decision. Is this cancer or is it benign? Is it an infection? Having decided that it's cancer, he would have to decide whether this is a cancer that is originating from the lung or whether it's coming from somewhere else. And then if it is a tumor that is originating in the lung, he probably would have to decide whether it's a small cell cancer or a non-small cell cancer. And basically they would stop at that. A few years later, the non-small cell cancers were further dissected into whether they were squamous or a glandular type of tumor or a large cell type of tumor. And then again, that would be it. Most of the time, these patients would be treated as with a regimen that was small cell or non-small cell. Subsequently, what has happened is that we are now able to analyze these tumors at a molecular level. And what has become very clear is that a tumor may be diagnosed as a non-small cell lung cancer in one patient, and in the second patient, it may be diagnosed again as a non-small cell lung cancer. Perhaps even both of these tumors may be called an adenocarcinoma, which is a type of a glandular malignancy. But at the molecular level, these two tumors, although they look almost morphologically identical under the microscope, are completely different tumors. And we would not know this unless we performed molecular analysis. And that has changed the way that we manage lung cancers, because each individual tumor with its unique molecular fingerprint is being managed differently. There's a drug that specifically targets a particular mutation, for example, an EGFR mutation or an ALK mutation. And patients with a different type of mutation, which is driving the tumor, and that's why we call these driver mutations, are managed differently. And without that information, this kind of sea change in the way oncologists manage lung adenocarcinomas or non-small cell lung cancers could not have happened. And that is really the exciting part in the way that we have started to diagnose these malignancies.
Right. So what used to be just small cells versus non-small cells are now evolving into classifying it further, what those small cell cancer types are like, those non-small cell cancers are like, right? But Dr. Anand, with all that advancements happening, I would assume on your side of the table, when you do resections and all that, do you see some of these changes impacting the patient outcome, the way you're treating patients as well?
Yeah, absolutely. Very, very much so. I echo what Prof. Padma is saying. In simple terms, it used to be just the stage of the disease, right? That's with any cancer, lung cancer, there's only 4 stages to the disease. And as we all know, stage means the extent of spread. And the stage of a disease, in this case, we're discussing lung cancer, will dictate the treatment that is offered to the patient and the prognosis or the outcome. But in recent years, as you mentioned, Prof, the tumor biology is almost as important as the stage of disease. So we are truly in the realms of what I would call as precision diagnostics and personalized treatments. So obviously, as a surgeon, we operate on mostly early stage lung cancer, which by definition is stage 1 and stage 2 disease. And about 20 to 25% of stage 3 may also be amenable, appropriate for surgery. But we recognize that surgery, for example, on its own is not good enough. It's inadequate. It has to be part of what we call as multimodal therapy, surgery in combination with other treatments such as chemotherapy or immunotherapy, or as Prof mentioned, if you have a driver mutation, perhaps oral targeted therapies. Sometimes we would deliver these treatments or give these treatments before surgery. This we term as neoadjuvant treatment, to shrink the tumor and increase the likelihood of successful removal. We call this a downsizing or downstaging effect. Sometimes it is given after surgery, even though we have fully removed the tumor and all the associated lymph nodes, to give the patient the best chance of a good long-term cancer-free survival. The metric we use is disease-free survival or event-free survival. And recently, in the last few years, there is growing evidence for a combination, what I call as a sandwich protocol, Prof, right? Where we give the treatments before and after surgery. But, the short answer to your question is the tumor biology will very much guide us as clinicians, and especially the treating pulmonologists, chest physicians, or the oncologists, in terms of the treatment pathway, the treatment paradigm, whether to offer a patient immunotherapy or oral targeted therapy in combination with surgery for the early stage disease. Yeah.
I think those are all very promising, very exciting news for clinicians, but also for lung cancer patients. Although I do have to bring up this statistic to both of you and see what your thoughts are, right? Unfortunately, until today, 90% of lung cancers are still detected late, stage 3, stage 4, right? Why is that still the case, right? Peculiar question. And at the same time, why is late detection often equated with worse outcomes?
I mean, it's a great question, and it's a very fair question. So certainly with lung cancer, the problem is, at the early stages of the disease, very often there are no signs or symptoms. I'm talking about stage 1, stage 2, sometimes even early stages of early subgroups of stage 3. So by the time someone presents with those classic symptoms, having a recurrent chest infection, having a cough, coughing up blood, what we term in medicine as hemoptysis, or more ominous signs, losing weight, loss of appetite, those are usually indicative of more advanced disease. So the difficulty, and this is not unique to Malaysia, it's a global problem, is in the early stages of this disease, unfortunately, there are very little signs or symptoms. So the key really is to screen high-risk or at-risk individuals when they are still what we term as asymptomatic. But of course, for screening to work, to be cost-effective, and to be impactful, it has to be both large-scale and it has to be targeted. And probably we'll talk about that later, which are the individuals who should be offered screening. So that is, in essence, why patients often present late, because they have no signs or symptoms in the early stages of the disease. Yeah.
I think I echo everything that Dr. Anand said. Unlike other organs, a lung actually has relatively less pain receptors compared to other organs. So unless the tumor is growing very close to the chest wall and infiltrates a nerve, it can grow to a fairly large size before it gets detected. And these patients remain asymptomatic until, they develop breathlessness or the tumor erodes through a vessel and they have cough up blood. So these are some of the reasons why most of our patients, not just in Malaysia, but globally, they tend to present late, unless there are nationwide screening programs which are targeted at picking up these patients early.
Okay.
Can I just add, Leonard? So exactly, it's the size and the location of the tumor that would often dictate or manifest in terms of the symptoms. So when you have a small tumor, exactly what Prof said, not close to any major structure, then it'll happily just grow away and keep, dividing without any symptoms, and unless you get screened.
So unfortunately, there really isn't a templated sort of presentation for lung cancers, and it can be quite non-specific in that regard, it sounds like. And I do want to talk about screenings in a short bit, right? But I want to wrap up this segment in a sense that we spoke a bit about some advancements, and I think we've already hinted at some of the new things that can be done for treatment. But ultimately, I believe one key question that many people are asking today with all these advancements, right? Is lung cancer still a death sentence as it was 10 years ago?
While I think the best chances of cure are for early stage tumors, patients with advanced tumors are living longer and longer. And this is because of the availability of targeted therapy. And it would be very fortunate if the patient has a mutation or a molecular fingerprint in his tumor that can be targeted with the treatments that are available. So, no, I don't think it's a death sentence, but we are able to improve the quality of life. We are able to prolong life. So we're talking about overall survival. We're talking about progression-free survival. And these are realities with the way that the major advances are being made in the management of lung cancer.
How has it been 10, 15, 20 years ago and where it is now today are you seeing patients with totally different outcomes, totally different thoughts and treatment modalities?
We have a lot in the toolbox now, not just surgery or radiotherapy. We've got oral targeted therapies, immunotherapies, antibody drug conjugates, a lot of fancy drugs. And it's a combination of these treatments which has translated into better outcomes in terms of patients living longer and also quality of life. Obviously, as a surgeon, a lot of what I see and treat will be earlier stage disease, which, as we mentioned, is usually we hope to cure the patients. But we are involved in the care of patients with more advanced stage disease these days, including stage 3. When I talk to my colleagues, the oncologists and the treating chest physicians or pulmonologists, they're increasingly reporting seeing patients with more advanced disease, living very well and for many, many years. So we really have to shift the focus towards cancer survivorship. You survive the initial treatment and you're doing very well. The Americans use the term thriving, very American, thrivers, or cancer survivorship. And that entails a different set of problems, trying to return to your normal lifestyle. Surveillance is very, very important. They will need to be monitored meticulously, which is usually with regular scans every 6 monthly, either a CT scan or a PET scan. What we are looking for is a relapse or recurrence of the disease. And if you pick it up at the earliest time point, it offers an opportunity to intervene either with further surgery or radiotherapy or some other medication or combination of treatment.
When you say thriving, are you thinking of any particular patient in mind? I'm trying to imagine an individual, right? What does thriving look like now and what does thriving look like back then?
One of the things I have spoken about this in the past is I term this the changing face of lung cancer. It was traditionally a male smoker's disease and kind of middle-aged or older men and kind of a working class disease. But the whole patient demographics in Asia and certainly in Malaysia has changed a lot. More than half the patients I operate on for lung cancer are non-smokers and often women. And, they're fairly young as well. As Prof mentioned, they're often at the peak in the prime of their lives, in their 40s, 50s. And this is a disease that doesn't discriminate. So when we talk about, it's hard to give you an anecdote off the top of my head, but, we see patients after successful surgery and the other combination treatments returning to a normal active lifestyle as hands-on parents or back in their whatever profession, they're in. And they would come to the clinic for a follow-up appointment and would not remotely look or resemble a cancer patient. And that gives us immense joy, seeing patients, literally thriving, healthy and well. There's, of course, always an element of anxiety in the days or weeks leading up to the next follow-up surveillance scan, but that is inevitable.
But you are giving more good news these days.
Absolutely. Even in the more advanced stage disease, I think, it's far from a death sentence.
All right, so I want to move on to something that's a bit more pragmatic, things that people can take home and learn today, right? So we've roughly alluded this a little just now, which is lung cancer being hard to screen, right? I think there was some mentions about the fact that it's non-specific, it presents itself in different parts, there are different cells. But beyond that, is there any other reason why lung cancer is really that hard to screen?
So, as we mentioned, for screening to be impactful, to be cost effective, it has to be targeted. And screening for lung cancer has been shown to be effective. The gold standard is using something called a low-dose CT scan. And there's quite a lot of evidence and data out there that it does result in a reduction in death due to lung cancer, what we call as a reduction in lung cancer-specific mortality. And that is done by creating impactful stage shift. In other words, we hope to pick up more people at stages 1 and 2 before they enter the health system at stage 3 and stage 4. And as we all know, the earlier any cancer is picked up, the more amenable, the more likely it is it can be treated with a curative intent through a combination of treatments. And so for lung cancer, low-dose CT scan is the way to go. The uptake for screening, however, not just in Malaysia, across the globe is pretty low. Now, one of the reasons is I think it's a human factor, isn't it? Yeah. The fear of a cancer diagnosis. Sometimes there are real-world concerns of cost, radiation. The main group that we have targeted historically, and rightly so, up until quite recently, are smokers. So tobacco smoking still the most identifiable and most preventable risk factor for lung cancer. And although we have witnessed this growing phenomenon of lung cancer in non-smokers or never smokers, a majority of whom are women, still, the majority of cases are still in current or former smokers. So you have to target those with a significant smoking history. But here's the thing, right? Smoking is a very addictive habit. It is enjoyable for many. And it's a hard sell to persuade someone who may have no symptoms, i.e. a smoker or a former smoker, to come forward for screening. But the other group, if I can just add briefly, that we need to target, we recognize this growing phenomenon of lung cancer in the non-smoker or never smoker, a majority of whom are women, will therefore be what we term as the high-risk never smoker or non-smoker. And we know air pollution, exposure to secondhand smoke, these are major risk factors, but they're very difficult to quantify. If I were to ask either of you, what is your secondhand smoke exposure risk or air pollution risk, it's impossible to quantify. However, we know family history is very significant. And if I were to ask anyone, you would know if you had a close relative, a first-degree relative like a sibling with lung cancer. So we now recognize, particularly in Asia and in Malaysia, that a salient history, family history of lung cancer, even if you're a non-smoker or never smoker, that's the other cohort, a group of individuals that we advocate screening for.
Right. So family history and
Absolutely.
smoking behavior patterns, right? These individuals then are encouraged for a low-dose CT scan?
Yeah, I mean, we add in, so what we do is there's a lot of data from various trials. And then I always say it's important to contextualize with local demographics, what we call as the ASR, the Age Standardized Incidence Rate. And we know in Malaysia for men, it goes up after the age of 45 and women after the age of 50. So those two groups, current or former heavy smokers, or those are the family history of the disease. But then to make it cost effective and impactful, you need to target age group. And usually it's 40 or 45 years of age and above. Yeah.
Right, so there's an age group, there's some behavioral, habitual risk factors, and then family risk factors as well, right?
That's right.
Just to throw the ball to you a little bit, Prof. Efma, from a pathology standpoint, are there any tests that is now potentially a part of screening that people can take note of?
A lot of people in the past have used biochemical markers such as CEA and CA19-9 and some other markers.
Blood cancer markers?
Blood cancer markers. What is emerging as something that is perhaps exciting, although it's still being validated in large clinical trials, is liquid biopsies.
Okay.
And these sometimes look for a specific type of cancer and sometimes multi-cancer. And it's based on the fact that tumors, as they grow, these tumor cells will die. And when they die, they shed their DNA into the blood. And by doing a blood draw, we may be able to detect these so-called circulating tumor DNA fragments. Now, it's promising, but in my opinion, it's not ready for showtime yet. It needs to be properly validated, and there are just too many variables. Large necrotic tumors tend to shed DNA, and very small cancers tend not to. So the risk is that you may do a test and it may come out negative, and the patient may actually have a tumor, except that it is small, it may not be shedding DNA, and therefore that's a false negative. Or you may have a huge tumor, and usually these labs don't have the benefit of looking at the patient. All they get is a blood test to be done. And if the tumor, large though it may have spread all over the body, but it's not a shedding tumor, then the test will again come out as negative.
Right.
And I've talked about the false negative, but what about those cases which are false positive? And we know that there are cases where there are false positives reported by these tests, which purport to pick up early cancer. That itself is quite harmful because it would lead to a lot of anxiety on the patient's part, the families, and it might lead to unnecessary testing. It might need to additional imaging, which may not be beneficial in the long run.
With the liquid biopsy or ctDNA, I completely agree. I think at the moment it's very exciting. We're hopeful, but it's not ready for prime time as a screening or diagnostic tool. But I'm sure Prof will agree, where we find great use potentially is in confirmed cases of, say, in this case, lung cancer, to monitor the response to treatment, whether it's curative surgery or some form of treatment, chemo, immunotherapy, and to look for, at a molecular level, residual disease. So the term we say is MRD, which means minimum or molecular residual disease. And it's useful to guide us as clinicians sometimes in terms of after surgery, for example. If there's no detectable cancer cells in the blood, we say they are ctDNA negative, the liquid biopsy is negative, there may be a potential to de-escalate the treatment. Maybe you may give the patient less cycles of chemotherapy or shorter duration. But still there are concerns. There's what Prof mentioned about false positives, false negatives, the sensitivity, the specificity of these commercially available assays. And it's just one important extra data point. So as doctors, as clinicians, we look at the imaging, we look at clinical risk profiling, as well as the molecular profile. But it is very exciting.
Yeah.
And I think as time goes, technology improves. Certainly it may have a role, to guide, personalize the treatment for patients, including, for example, personalizing surveillance scans, the threshold at which we would investigate the patient. As what you've mentioned, biopsies don't, there's a risk involved in anything we do.
I think ultimately in medicine, the first rule of medicine is always do no harm,
Absolutely.
right? And I think you're right. And it's a tricky balance, I feel, because on one hand, you've got people who are so anxiety-ridden, they want to screen everything and anything. And then you've got the other hand who doesn't want to get anything screened, right? In fact, I had a patient who just got referred. The anxiety of waiting for the result caused a tremor, and then she wanted to book a neuro consult, right? But coming back to topic, then we're still sort of this very awkward position whereby we clearly can't offer everyone a low-dose CT scan. People who are not smokers are getting lung cancers in some cases. So how do we go about this? Like, what's practical for people to take away? I'm sure if you've got risk factors, sure, but what about those who don't have risk factors, right? It doesn't sound like we are out of the woods just quite yet.
To address the issue about screening, so the gold standard is a low-dose CT scan. It does what it says on the tin. The radiation dose is very low, 1 to 3 millisieverts. But there are issues of cost. Yeah. There's issues of accessibility. Yeah. There's the human element, fear of a cancer diagnosis. So you're probably aware the government, through the Ministry of Health, has embarked on this lung health initiative to try and screen for lung diseases, including lung cancer. And I think they're on the right path, where it's framed as a part of a broader lung health check. So maybe it's less daunting for people, for patients. And they are using chest x-rays. And I'm quite happy to share the NGO that I lead, Lung Cancer Network Malaysia, we actually pioneered the use of AI-enabled chest x-rays here in Malaysia. And we demonstrated at community-level screening a few years ago that it is feasible, it is scalable, it can be used. The technology can be deployed remotely to, for example, screen remote or rural populations. You don't need a highly trained radiologist on site. Now, screening for lung cancer with x-rays is not new. The Japanese were doing it decades ago, but it's been shown to be not good enough, not sensitive or accurate enough, the diagnostic accuracy. But what's happened in the last few years is with AI technology, the algorithms have enhanced the diagnostic sensitivity and accuracy. And, there's a lot of evidence to suggest that this is a reasonable way to go in low and middle income countries such as Malaysia. It's better than not screening at all. So my position on it is very clear. It should be used as a triage or a funnel. And then when you find an abnormality on the X-ray, they should then go on to have the definitive scan, which is a low-dose CT scan.
If you have a strong risk factor, let's say a familial history, a habitual smoking pattern, for example, and let's say you're in the age of 30, for example, do you then immediately ask for a low-dose CT scan with every health screening?
That's difficult. I mean, as I said, for screening to be cost-effective, to be impactful, we have to, you have to cast the net wide, but also at the same time, you've got to be targeted. Yeah. So I think individual cases, you have to look at it. But broadly speaking, we would advocate screening only for current or former smokers or those with a strong, clear family history of the disease over the age of 40.
Okay.
Now, we've all had patients under 40 diagnosed with lung cancer, but those would be the the exception rather than the norm.
Clinical outliers aside, I think you've already mentioned and established the fact that we are seeing more females, for example, developing lung cancers. Now we know for those who with risk factors, 40 years old and above, it's a conversation worthwhile being had with your primary care physician, maybe even a low-dose CT scan, etc. But for those listeners today who are perhaps female, right, no classical risk factors, what can they do?
Yeah, so it's quite difficult to sit here and advocate broad-based screening. We look at our local demographics. We know if you're ethnically Chinese, your risk of lung cancer is twice that of a non-Chinese, a Malay or Indian, adjusting for age and gender. But it's not going to be logical or feasible to ask anyone of Chinese ethnicity to come forward for screening. So we still have to focus on age as one of the variables. And, over the age of 40 or 45. Lung cancer in those under the age of 40 is exceedingly rare in Malaysia. The incidence is less than 5%. We will all have cases, but that would be more, as we said, the outlier, the exception than the norm. So I would still strongly advocate those with either a significant smoking history, 20-pack year history, or smoking for 20 years, current or former smoker. And also those who have a relevant, or what we call as a salient family history of the disease. So you have a close relative, a first-degree relative like a sibling, then unfortunately that person has an elevated risk of lung cancer. And these are the groups that we would recommend and advocate screening for.
And when you say screening, do you mean immediately for the low-dose CT scan or cancer markers first, or what are you referring to?
Sure. That's a great question. So I think the gold standard is still imaging, either a low-dose CT scan. If for whatever reason it's either not affordable or accessible, then try to get a chest x-ray, and preferably one that is enhanced with AI technology. Also not unreasonable is blood tests, like a cancer marker, although as we've mentioned, these are non-specific. So if you have a elevated blood test, it may not necessarily mean there is underlying cancer. And conversely, having a normal cancer marker blood test also doesn't completely exclude the possibility of one having cancer. But, as I said, as doctors, as clinicians, we use all of this as to create a composite picture, clinical picture. So we don't rely on just one data point in terms of the diagnosis and in terms of managing a patient.
Got it. And that's primarily for people with risk factors, as we've discussed. And for that female Chinese population with no classical risk factors, is there any harm for them to do perhaps a chest x-ray as part of their routine health screening?
Yeah, I mean, so we have seen a disproportionate number of genetically or oncogene-driven lung cancer, mainly in non-smokers of Oriental or Chinese ethnicity above a certain age group, and often driven by EGFR, a common driver mutation. But again, it's very hard. I mean, I don't know how many millions of patients or individuals, and they're not even patients, would be in this category. So difficult to say all get screened, but a chest x-ray is a very commonly ordered and available baseline investigation, not unreasonable. I'm hesitant to recommend that because the whole premise of screening is to pick up the tumor or disease early, and conventional x-ray is probably not going to be good enough to pick up something small. It'll have to be fairly big before it is going to be visible on an x-ray. So an AI enhanced chest x-ray is certainly better, but the gold standard is a low-dose CT scan.
Okay. So the last thing I do want to just touch about before we wrap this segment is in oncology, typically we also talk about symptoms and just being mindful about symptoms as well, right? Like, for example, in the case of brain tumors, if the headaches are persistent, they're getting worse, for example. In the case of lung cancers, right, especially for those with no classical risk factors, are there symptoms that people should look out for and raise red flags to go and see an oncologist?
Yeah, definitely. I mean, so as you say, we call these red flag symptoms. And I think we discussed at the start of this discussion, this forum, that the symptoms are manifestation of the size and location of the tumor. So the things you look out for is, even if you don't have classical risk factors, if you have recurrent chest infections, you're having difficulty breathing, unexplained loss of weight, loss of appetite, fatigue, shoulder or bone pain, and of course something more ominous if you're coughing up blood. these certainly are red flag symptoms, not just for an individual, but for our colleagues in primary care to not ignore.
Yep.
You've got to have a very low threshold to then get it investigated. As a minimum, see your GP or see a lung specialist. As a minimum, get a chest x-ray.
Got it. So if you have classical risk factors, you're a smoker, you are exposed to certain hazards, it's worthwhile if you're above the age of 40 to get screened. If you are a non-classical individual of Oriental descent, for example, probably fine to get a chest x-ray as part of a screening with enhanced AI features. But more importantly, if you present with certain symptoms like coughing blood, for example, shortness of breath, talk to your primary GP and get that referral to investigate further to make sure that it's nothing serious. Thanks for listening in, and I hope you're enjoying the episode so far. If you find the message meaningful, share this to somebody close to you or a loved one. Last but not least, really important conversation about treatment, right? We've roughly alluded this a little bit, and I want to start with you, Prof. Pathma. We hear the term personalized treatment or personalized diagnostics, for example. Are we saying that 10 years ago it was all blanket treatment? Is there differences?
Yeah, pretty much. I think, and Anand can probably correct me on this one, but we have moved away from just treating them with chemotherapy. And the dangers of that, of course, is that in addition to killing the cancer cells, it will also kill normal cells. Patient suffers from side effects, hair loss. We all know about all of this, nausea, vomiting, gastrointestinal tract symptoms, and so on. With the advent of targeted therapy, the moment we start drilling down to the presence of a driver mutation, we can now exquisitely target that cancer cell, specifically that driver mutation. And we have drugs that do this. And the list of driver mutations is growing almost every year. And when we started, we talked about EGFR, we talked about ALK and ROS. But today, we have more than 60% of non-small cell lung cancers are being identified as having some kind of driver mutation that can be targeted. And this list is going to grow as the science advances. Not just the fact that there are driver mutations, and the science has grown to the point when we can detect genes that may act in concert or together with these driver mutations and either increase its targetability or actually diminish the value of targeted therapy in these patients. So one known gene that we speak about is the P53 gene. And having a P53 gene tends to blunt the effects of chemotherapy or targeted therapy. And also evidence is emerging that these tumors may actually have the propensity to recur earlier. So that information is not just looking for a driver mutation, but looking at other mutations that participate in this landscape, this interplay of genes that actually make the treatment more effective or less effective. Now, there are many headwinds. As the tumor is treated and it regresses, we have technologies in place to look at the presence of emerging resistance mutations, because the cancer gene is a selfish gene. It wants to live. And therefore, it's trying to survive in an environment where it's being bombarded with drugs, where we are harnessing the powers of immunotherapy. So the technology exists now for us to pick up the driver mutations as they turn up. And if there is therapy available to target that, then well and good. So it is a constant battle between pharma, the pathologist, and the cancer cell, trying to unravel what new resistance mechanism the cancer cell is clever enough to employ, and how we can do to counteract that. And we alluded to this before, that, where the diagnosis of lung cancer is a death sentence. But I envisage that as knowledge accumulates, and as Anand mentioned, that these are going to be regarded very much like chronic diseases. We stay one step ahead by targeting resistance mutations. And maybe one day, lung cancer may be something akin to chronic bronchial asthma, where we just continue to treat them, and the patient, some of these patients may die of non-cancer related diseases, either sometimes, unfortunately, complications of the therapies, heart disease, a stroke, renal failure, and not because of the cancer per se killing them.
Yeah. So this type of sequencing and testing, is it what we now know as next generational sequencing?
Next generation sequencing is a term that is just used to determine the kind of mutation that is present in the cancer cell. It's a sort of very broad-based term, sometimes referred to as comprehensive genomic profiling. Next generation because it moves beyond the way we used to test, where we used to look at single genes using polymerase chain reactions and so on. So now we can actually, with next generation sequencing, interrogate millions of genes all at one go. And this has shortened the time where we can actually identify a mutation, where in the past it used to be a stepwise process where we would look for one gene. If it's not present, we look for another gene, and so on and so forth. And we run out of this problem where the tissue is depleted. As you probably already know, most of these patients present in stage 4, and they can't be cured. So what we do is we biopsy them, and a biopsy sample is usually a very short sliver of tissue. And we must be very judicious about how we use that tissue, conserve as much of it as possible to identify the driver mutation, which really is the thing that is going to influence how we're going to manage that patient. Right. And with a sequential kind of a testing where you test for one gene and then another and another, we run out of material. Whereas with next generation sequencing, we can interrogate, as I said, millions of genes all at one go, and pick up a lot of information, not just about driver mutations, about other genes which may confer an adverse prognosis, or may actually augment any kind of targeted therapy working in concert with the driver mutation.
Wow. I want to invite your comments in a bit, Dr. Anand, but it sounds like now these days we can identify the mutation specifically and have corresponding medication or therapies to suit that specific mutation. And if once treatment has been done, you test it periodically, and you almost like a prophylaxis in a way. It sounds like. Is that the correct train of thought?
I think we wouldn't test until the patient's tumor recurs,
Yep.
or there is evidence that there is emerging clones, as evidenced by minimal residual disease or circulating tumor DNA titers rising. And we'll be able to, even through a liquid biopsy, determine whether it's rising because the therapy is not working, or whether there's a new resistance mutation. So we can intervene early.
Okay.
And early intervention means that we're doing it at a point when the disease burden is still low, and the chances of success is better.
Got it. So Dr. Anand, right? Imagine, a cancer patient comes through the door, they've been diagnosed. Help me understand the treatment process now with all these new sequencing technologies. What should people take note of these days?
So we're very mindful, it's an incredibly stressful time for a patient and the caregivers, the family, when they come through the door. Sometimes there's an established diagnosis already, a histological diagnosis of lung cancer from a biopsy. Sometimes it's a clinical diagnosis that they haven't got to that point. It often depends on what is the stage of the disease. The typical investigations you need to do are, as a baseline, a scan of the chest, a CT scan, and then we do what is known as a staging PET scan, positron emission tomography. It's a whole body scan using radioactive glucose called FDG, and it works on the principle that cancer cells have increased metabolic requirements. The PET scans are good. They're not perfect, but they're very good. They have about 80-85% sensitivity, specificity. And that's important to try and stage the disease. So you have a confirmed or suspected lung cancer, and we need to determine whether that tumor is confined to the lung? Has it spread to the nearby lymph nodes? Has it gone to other sites in the body? And as we all know, the common sites where lung cancer can spread, process known as metastases, is either unfortunately to the brain or to bone, to the opposite lung, sometimes to the adrenal glands. And I think we mentioned earlier, it is critically important to establish the stage of the disease because that will dictate the treatment that is offered to the patient, what we call as stage appropriate treatment, the treatment intent, and also the outcome, the prognosis in terms of survival and cancer-free survival. So typically when a patient comes to the clinic, when I see a new patient, it would take on average about an hour to go through all the investigations and talk to the patient and the family of what are the possible scenarios. And I'm extremely mindful that this is a very stressful time for the patient and the family. And our duty is to obviously provide relevant information for them to then make informed decisions, informed choices on the next step. I think the thing I want to just add is, with the exception of a few patients with very early stage lung cancer, practically all patients these days require what we term as a multidisciplinary approach and a multimodal approach. So the optimal care, will require expertise from the primary care doctors, the chest physician, thoracic surgeon, the oncologist, the histopathologist or molecular pathologist, interventional radiologists to get the biopsy, the nuclear medicine specialist in terms of the PET scans and staging of the disease. So a lot of cross-disciplinary or multidisciplinary expertise. We work as part of a team and a lot of scans and imaging. And usually the best outcomes are achieved through a combination of treatments. If it's early stage, surgery is the definitive treatment, but not good enough on its own. It must be paired with chemo, radio, immuno-targeted therapy based on the biology of the disease, sometimes either given before or after the surgery.
Yeah. So I think that's really hopeful, I feel, because like these days what that means is that with the correct identification of the driver mutation, the clinicians can now advise whether certain chemotherapy combinations or certain modalities will work better than others, right? Which is really promising news. Prof, how far are we from what you've described as the era whereby lung cancer is just like asthma?
Well, we are quite a way off.
Okay.
And there are important factors to take into consideration. First of all, I think we have to contend with the fact that most of these patients are presenting late. And therefore they're inoperable. The second thing is that although we have all this wonderful technology, next generation sequencing, detection of minimal residual disease through liquid biopsies and so on, it's not universally available to everybody. Okay, globally and also in this country. And there used to be a sponsorship program where pharma used to chip in to pay for this expensive testing, but that's no longer in existence. So it's an out-of-pocket expense. Some insurance companies may cover it, others may not. So having lung cancer and having the promise of targeted therapy doesn't mean that everybody gets tested.
Right. So access to healthcare.
Yes. So that's the factor number two. The third factor is that the drug availability. Some drugs may work exquisitely with a driver mutation, but they are not approved for use in this country yet. The other is the cost. The cost of these drugs is expensive. It is expensive. And depending on your healthcare program provider, it may or may not be covered. Insurance companies may not cover. It depends also on the kind of policy you have. So you may be able to get treatment for a while, but not in perpetuity. And many of these treatments require fairly long-term treatment. And then, of course, as I've told you before, lung cancer, the cell wants to survive. So it's chronic because it's not a one-hit. You kill the cancer cell, the patient is cured. The cancer cell, whatever residual cancer cells, are learning how to live to the next day. they are finding ways to resist the immune response, developing alternate pathways so that they now become unresponsive to that drug that used to work so well with it before. And therefore the disease emerges.
Right.
The patient becomes sick.
Yeah.
And sometimes to the point when the disease becomes so rapidly growing that they develop brain metastasis and they die before we can even decide what's wrong with them.
Yeah.
So liquid biopsies, while they hold a lot of promise, they are not as good as a tissue biopsy. And depending on various factors, although the specificity is high, the sensitivity is in the region of 75 to 80%. So there will still be a subset of tumors which you're going to miss. So there are a lot of problems. And if we can address most, if not all of this, then I think the reality of making lung cancer disease chronic, like bronchial asthma or a chronic lung disease that is non-lethal, is something that is not beyond the realm of possibility.
Right.
But until we address these, I think we are moving in the right direction, but we are not there yet.
Right. It sounds like it's so multifactorial, right? So it's a part of access to healthcare and good quality healthcare, but it's also it's a speed. It's a race against time to develop the new modalities, drugs, treatment to match the rate of these mutations that we are picking up in patients as well. Question to both of you, and I think Prof, you've alluded this really well, which is access to healthcare, right? And I think a lot of times people are also wondering if, touch wood, I've been diagnosed with a type of lung cancer, for example, and now I want to seek intervention and treatment support. What are some of the important, I suppose, metrics or important things that people should look out for when deciding their place or their point of care? Are there things that people should take note of regarding treatment?
Well, I mean, I think, Prof mentioned broader issues of what we call as financial toxicity in terms of affordability and access to drugs. But when we're dealing with especially earlier stage lung cancer, but for that matter, any stage of the disease, the time to treatment initiation, is critically important. There's a lot of data and evidence, published data to substantiate that the shorter that interval, the turnaround time, the whole diagnostic staging workup, the time to treatment initiation impacts on the outcome. So it's important that, we shorten that whole journey for the patient. And to be able to access, what will determine that is having a good multidisciplinary, cross-disciplinary team and having the necessary resources in terms of imaging, molecular lab, and so forth, so that you shorten turnaround time, you expedite the diagnostic staging process of any case, and then you can commence the treatment, which is obviously dictated by the stage, be it surgery, be it chemotherapy, immunotherapy, the oral targeted therapies. So I guess as daunting or as stressful a time it is for anyone who is then diagnosed or suspected to have lung cancer, you need good support, family support, caregivers to support you. But on the professional, medical or scientific side, it's important to access treatments. And this will also depend on the financial means and geographical location, where you are in the country or where you are in the world. But if you go to big designated cancer centers, where you have all the facilities, all the resources in one site, and the necessary expertise. Often what we do is, and we didn't mention this, is we term this as a MDT, multidisciplinary, or the Americans, we've now used the American terminology, tumor boards. And we often discuss, with the exception of the most routine case, we discuss the patient's individual cases as a group to try and arrive at the best possible treatment or management plan for an individual patient based on real world considerations, based on the tumor biology, based on the stage of the disease. And then that is communicated back by the primary physician, be it a surgeon, oncologist, or a chest physician to the patient and family. And at those tumor boards, we would have people like Prof. Fatma, we'd have a pathologist, a molecular or histopathologist, you'd have a surgeon like myself, for example, you'd have oncologists and all the other specialists giving independent professional opinions from their points of expertise with an aligned goal, which is just to offer the best treatment plan for an individual patient. Yeah. So that's very important, having the facilities, having the expertise, having the resources so that you can move in a very timely manner.
Yeah. So resources to enable treatment and action fast.
Absolutely.
Right. Prof, what are your thoughts on that matter?
Yeah, I think everything that Anand has alluded to, I think multidisciplinary approach is key. To me, when we're talking about targeted therapy, the quality of the reporting and the results is very important. Therefore, it is important that the results or the testing be performed in a lab with proper accreditation, that the next generation sequencer will churn out a lot of data. It's very important for a molecular pathologist to actually be able to curate that information and filter out the stuff that really is just garbage, it's noise in the background. And this is quite important. It will identify the true driver mutations and separate that from the genes which are actually not nonsense genes. And therefore, the accreditation of the lab that is generating the next generation sequencing data is very important. And I think it is important that that lab be accredited and participate in quality assurance programs and perform well, because these are life-changing therapies, but only when the results are meaningful and can be trusted. And I mention this because having worked in the field for many years, and there are many players in the field, everybody wants to say they have a next generation sequencer, but not all the sequencers are the same. They are from different vendors. And for the results to be meaningful, I think these has to be validated and benchmarked against the available good standards and international guidelines. So I think garbage in, garbage out. If the results are wrong, or if the results are or if there are no results, then that clinic, nothing can actually be set forth. All that therapy cannot take place, promising though it may be. And we've had examples in our laboratory where, these are causes for concern. Yeah.
So having the multidisciplinary team, the professional, the clinical expertise, the facilities, but facilities-wise, they have to be internationally accredited, ideally, to make sure that, when we don't want to test patients for the sake of testing, we want to get meaningful results, right? As we round up the session today, right, we spoke about the fact that things are moving positively. It is promising with how AI is helping with screening, how some of the treatment modalities is improving, the way we are sequencing the driver mutations, and that corresponding to the relevant targeted therapies as well. What are some of the key takeaways that you want audiences to remember from today's session from either your side? Maybe we can start with yourself first, Dr. Anand. What are some of the key takeaways that you think the public should remember from today's conversation? What would you like them to remember?
Well, I think for all the tremendous advances, that we have talked about, in terms of be it molecular profiling, next generation sequencing, we haven't talked much about surgery, but these days we perform operations through a less and less invasive approach. We've talked about screening, AI, cutting edge low dose and ultra low dose CT imaging. And for all these tremendous advances, as well as all the game changing drugs, oral targeted therapies, immunotherapies, which are translating into better outcomes, I still hold the opinion that, the two single most important things will be preventative. And by that I mean tobacco control, right? So it may not be a sexy scientific message, but really don't smoke. Try to, certainly don't smoke. It's a lifestyle choice. It's more difficult to mitigate, to control our exposure to secondhand smoke or passive smoking. But I think preventative strategy, very important. In tandem with that, I would say screening. We've talked about this throughout today's forum, that the vast majority of cases are being picked up very late, globally, including here in Malaysia, for the very reason that in the early stages of the disease, it is often without any symptoms, what we term as asymptomatic. So if anyone listening is either in an at-risk group, current or former smoker, at least 20 years or more, or they have a significant, salient family history of the disease, like a first degree relative, like a sibling, then they should, I hope, explore, go and get screened. Ideally with a low-dose CT scan, but as a minimum with even a chest X-ray, preferably an AI-enabled chest X-ray, because I think that could save your life.
Prof. Prafma?
Yeah, I think what I would like to say is that the management, the diagnosis, and the way we look at lung cancer has changed so dramatically over the last couple of decades that it's almost as if we're not treating the same disease, because it is becoming very individualized, giving true meaning to the word individualized therapy, targeted therapy, the promise of precision medicine. And the kind of advances that we've made over the last couple of decades has been truly life-changing for many patients. And the science continues to advance. And I've alluded to this before, that we look forward to the day when, lung cancer, using your own words, is not a death sentence, but becomes a chronic disease, with us being vigilant, monitoring the patient, and trying to outthink the cancer cell, working in concert with pharma and fine-tuning our own diagnostic acumen to assist the patient and move this population of unfortunate patients forward.
Dr. Anand, Prof. Prafma, it's been a pleasure, very insightful. Thank you very much.